A warm good evening, everyone. Today we are on the second cycle of basic infectious disease lecture module. And today we are going to discuss a very fundamental topic related to infectious diseases. Today we are going to listen to antimicrobial drug dosing in hepatic and renal impairment. And we have a wonderful senior clinical pharmacist to talk with us today. This is Dr. Aisha Sana. She has been working in the Department of Clinical Pharmacy for the past 5 years. She's an excellent speaker and she have already taken many training sessions for aspiring clinical pharmacists and pharmacy students. She is also working as a team lead for our infusion newsletter by FCPI. So dear participants, before we start, I wish to convey a few messages. Please change the slide. If you have any questions, we are ready to take up your question at the end of session. So please comment your questions in the comment section. And for the feedback, we wish to hear from you. So kindly submit your feedback before the end of the session, and you have to submit before the session ends. And next, to claim your certificate, log into the FCPI website and download your certificate within 14 days of this event. And to refer back to the slide, you can download the slides from the FCPI website, and login is mandatory to claim the slides. So without a delay, let me hand over to Dr. Aisha Sana. Over to you, Aisha.
Thank you, Alina, for the wonderful introduction. Hi everyone. My topic for today is antimicrobial dosing for patients with renal and hepatic impairment. I do not have any relevant disclosures. So we'll start with the topic with a few concepts that is really important in the dosing of patients with renal and hepatic impairment. It is very important to consider these concepts before considering a dose modification. So first is, what are the principles of dosing in patients with renal and hepatic impairment? So first thing we have to say is the etiology of the abnormal renal and hepatic functions, the pharmacokinetics and pharmacodynamics of the drug, the risk factors of the patients. So these are important parameters that we must consider before intervening in these patients. We'll look into each one by one. So first, let's look into the factors that we have to consider in patients who have a hepatic impairment. Now, I'll be taking you through the risk factors of patients who have a hepatic impairment and who requires dose modification. So these are few of the conditions patients might have with a renal hepatic impairment and how they affect the drug bioavailability or the metabolism. And these are the reasons for dose modifications in patients with such complications. For example, if your patient has a hepatic condition like cirrhosis or hepatitis or etc., and these conditions can eventually impair the hepatic blood flow. So patient with a reduced hepatic blood flow will eventually affect the drug's first pass metabolism. That is, if there is reduced hepatic blood flow, the amount of drug that is the liver will receive for metabolism will be reduced. Hence, what will happen is the concentration of the unmetabolized drug in the serum will be high. So what will happen is the drug will be high in the blood and it will lead to toxic effects. So we have to consider dose modification in patients who have a impaired hepatic blood flow. Then comes the concept of hypoalbuminemia. Hypoalbuminemia means patients whose serum albumin level is below the normal. Those patients can be cirrhotic patients or hepatic carcinoma patients or patients who are in critical care or geriatric patients. So as you all know, albumin is a substance which the drug are binded to in the serum, and If a patient has less albumin, it will result in less protein binding of the drug. What will happen is it will increase the unbound fraction of the drug and leading to toxic effects of the drug. So we'll have high amount of free unbound concentration of drug in the blood. So what will happen is the drug's toxicity will affect the patient. Then the next condition these kinds of patients can have is ascites. It is one of the complications of liver cirrhosis and hepatic impairment. So even patients with ascites can have issues with the drug metabolism and elimination. Then further on, moving on, we'll have these patients will have reduced cytochrome activity. That is, the cytochrome enzymes like CYP450, all those enzymes concentration or activity will be reduced, eventually reducing the drug's metabolism and clearance. Then next is a concept of portal gastropathy. That is, patients who have a liver cirrhosis and portal hypertension will eventually have a complication called as portal gastropathy, that is gastritis and impaired absorption. So patients with gastritis or ulcers because of portal hypertension or cirrhosis, the immediate absorption of the drug from the GI tract is reduced, so affecting the clinical effect of the drug. Then these patients will also undergo multiple procedures like synaptic shunts and all to reduce varicose bleeding, etc., which is a complication of liver cirrhosis. So such patients who have undergone these procedure eventually can affect the drug's metabolism and clearance of bioavailability, etc. And then comes last is administering concomitant drugs which are hepatotoxic for patients who already have a hepatic impairment or excessive alcoholism in patients. So these all are factors or risk factors which we must consider in dose modification, or which requires dose modification in patients or for when you're giving a hepatotoxic drugs. Moving on, now we know why we have to consider dose modification in hepatic impaired patients. Next, we'll see how hepatotoxic drugs affects the liver and what are its clinical manifestations. We all know the drug gets uptaked into the liver, it'll get accumulated in the liver, and all the cytochrome enzymes are involved in metabolism and eventually clearance of the drug. So it can be the unbound drug or the bound drug that gets taken up into the liver and eventually metabolized, and then it is cleared off. So a patient who is being given with a hepatotoxic drug can affect the liver's mitochondrial or the cellular structures of the liver and eventually causing damage to liver structure. Then can result in few of the drugs can result in causing reactive metabolites, because the drug produces toxic substances in the liver, leading to chemical stress or oxidative stress for the liver tissues. And then is certain drugs can also cause immune related damage to the liver, leading to inflammation. So these are the different mechanisms of how drugs can cause liver injury. Then is the presentation of drug-induced liver injury. Drug-induced liver injury, like any other liver condition, will also present as fatty liver or lactic acidosis or hepatic necrosis, or they can lead to liver failure, or they can also present like viral like hepatitis. So all these are the different presentations of drug-induced liver injury. So now we have seen what are the risk factors for a hepatic patient and how the drug affects the liver, and then what are the presentations or how the patient presents with the liver injury because of a drug. Now we also need to understand the normal functions of the liver, which help us in dose modification for various drugs. First important thing is the SGOT and SGPT value. The normal is 4 to 36 IU per liter for SGPT and 5 to 30 IU per liter for SGOT. So if the normal or the patient's blood SGOT and SGPT value is more than 3 times of the upper limit of normal, we have to consider dose modification for hepatotoxic drugs. And then comes the bilirubin, that is 2 to 17 micromole is a normal, and albumin is 3.5 to 5 gram per deciliter. So these are the normal parameters we have to keep in mind. Then is the factors we have to consider for patients in renal impairment. So now I have a list of conditions which can cause renal impairment, or which we must consider for patients who are giving nephrotoxic drugs. So, one example is patients who are hypovolemic. Patients who are hypovolemic can be due to dehydration, excessive diarrhea, urination, or diuresis. For example, if a patient who becomes dehydrated, it is important to consider dose modification in such patients. Then is administration of nephrotoxic agents. Patients who already have a known renal issue are given nephrotoxic agents like contrast, dyes, ACs, ARBs, or antibiotics. Or patients who we give drug interactions which cause nephrotoxicity, or if there is lack of renal lossing, that also can results in renal injury. Then we also have to consider comorbidities of the patient. A patient with a CKD or heart failure, diabetes mellitus are also prone to further renal injury if we administer a nephrotoxic drug. Then underlying renal diseases like already known case of CKD or patients with reduced urine output are also increased risk. Then comes the critically ill patients who already might have a hemodynamic instability, hypotension, or lack of renal perfusion. Then the last is a patient-related factors like old age, increased weight, or recent surgeries. So these are a set of risk factors that will further increase the renal injury for a patient if we give a nephrotoxic drug. Then is the antibiotic drug causing the different mechanism of antibiotic renal injury are: one is acute interstitial nephritis, then acute tubular necrosis, and then is drugs which cause crystal nephropathy. So if you look into the antibiotic class, most common drugs that can cause acute interstitial nephritis are trimethoprim sulfamethoxazole, fluoroquinolones, vancomycins, penicillins, cephalosporins, astrinum, clindamycin, macrolides. That is, these drugs can affect the interstitium of the nephrons, causing inflammation of the nephritis. Then next is acute tubular necrosis, that is drugs like again vancomycin, trimethoprim sulfamethoxazole, cephalosporins, carbapenems, astrinum, amyloglycosides, clindamycins. These drugs can affect the tubules and cause necrosis of the renal tubules. Then next condition is called as crystal nephropathy. That is, drugs like clindamycin, cephalosporin, they might accumulate in the renal tubules and cause crystal nephropathy. Then other mechanisms of AKI from antibiotics are decreased tubular secretion of serum creatinine, detergent effect damaging the tubular cells, and free radical formations, hemolytic anemia and post-renal ureteric alkali, oxidative stress, drug interactions, etc. So these are the different mechanisms of drug-induced liver injury or the antibiotics mechanism. Okay. Now we have to also understand the classification of acute kidney injury based on the urine output and the creatinine value. So the first class of acute kidney injury based on the urine output and creatinine value is class stage 1, or patients who are at increased risk of renal injury. That is, if a patient has renal output less than 0.5 ml per kg per hour for more than 6 hours, or if the GFR is reduced by 25%, then and the creatinine is increased by 1.5%, these patients are at increased risk of an AKI. And so we have to dose the patients accordingly, or we have to consider dose modification in those patients. Then the next class is the patients who have an acute kidney injury, and the stage is 2. That is, if the urine output is less than 0.5 ml per kg per hour for more than 12 hours and the GFR is reduced by 50%, or if the serum creatinine increases more than 2 times the normal, those patients are staged at 2 with a injury of the kidneys. Then the last stage is stage 3, or the patients who are at failure. That is, the urine output is less than 0.3 ml per kg per hour for more than 24 hours, or those patients who are anuric, and or the patients which are initiated on a renal replacement therapy like hemodialysis, and the serum creatinine is more than 4 mg per deciliter. So these are the different classification of acute kidney injury based on uh, output and creatinine value. Moving on. Now we'll see the different pharmacokinetic and the pharmacodynamic principles we have to consider while dose modification in patients with hepatic and renal impairment. So first is drug pharmacokinetics. Pharmacokinetics means, as we all know, what the body does to the drug. So in pharmacokinetics, there is absorption, distribution, metabolism, and elimination. So why is pharmacokinetics important in hepatic or renal impairment? As you all know, the liver is involved in hepatocellular uptake of drugs, metabolism, and biliary excretion of drugs. And dosage adjustment is necessary to prevent an excessive drug or metabolite accumulation and toxic effects of the drug. On the other hand, the kidney is the major route of elimination of the drug. So, dosage adjustment is necessary to prevent any underexposure of medicines, which can lead to therapeutic failure, or overexposure of the drugs, which can lead to toxicity. So these are the reasons why we have to consider the pharmacokinetics and pharmacodynamics in the patient. Now we look further into the effect of liver dysfunction on pharmacokinetic processes. The first is how the drug and the active metabolites affects the renal injury. So we all know drug is the if in case of liver dysfunction, and if you're giving a drug which is more potent than the metabolite, the overall pharmacological activity will increase in hepatic impaired patients because drug concentration will be higher, and the drug is less potent than the metabolite. The overall pharmacological activity in the hepatic will decrease because the drug is less active than the metabolite. Next concept is hepatic drug clearance. Since there is no naturally occurring substance that can be used to estimate the hepatic clearance of drugs, the child score is used in liver patients to understand or assess the prognosis of patients with liver failure. So we use the child score to decide on the dosing of hepatic toxic drugs. Last is the hepatic blood flow and intrinsic clearance. If the drug has a high clearance, then that is high liver blood flow dependent, you have to reduce the dose by 50%. And if the clearance of the drug is low, that is it is independent of the blood flow, and all other metabolized drug, you have to reduce the dose by 25%. So that is a dose consideration based on the clearance of the drug. Now we look into the absorption parameters in hepatic impairment. Patients with chronic liver disease, the bioavailability of orally administered drug is varied. The absorption process of orally administered drugs might be altered due to portal hypertension, gastropathy, gastritis, or upper GI tract issues. The extent of drug absorption could be decreased as a consequence of these pathologies, or may be increased because of high intestinal permeability in patients with portal hypertension. Next concept is plasma protein binding. Chronic liver disease such as cirrhosis is more likely to be associated with altered drug binding than an acute condition such as viral hepatitis. Distribution of the drug within the body depends on its reversible binding to blood cells, plasma proteins, and tissue macromolecules. Drugs that are highly bound to albumin or alpha-1 glycoprotein have a significantly higher fraction of absorption in patients with chronic liver disease. Decreased binding of drugs can be due to reduced albumin and alpha-1 glycoprotein synthesis, accumulation of endogenous compounds such as bilirubin, inhibiting protein binding of drugs. Next, we look into the concept of distribution. Patients with liver cirrhosis, that is, patients with edema or ascites, the volume of distribution of hydrophilic drug is increased. Loading dose of hydrophilic drugs can be increased in cirrhotic patients. Water-soluble drugs will have a significant increase in their volume of distribution in patients with ascites, possibly necessitating larger loading doses. For example, volume of distribution of the beta-lactam antimicrobial ceftriaxone was shown to be 3 times larger in patients with cirrhosis compared to healthy individuals. Metabolism. Chronic liver disease is associated with impaired metabolism of a number of drugs. The reduction in absolute liver cell mass or a decrease in enzyme activity can be altered in the function of the surviving cells, which may lead to impaired drug metabolism. Elimination. An increase in the volume of distribution is associated with an increase in the elimination half-life of drugs. A slower elimination velocity in cirrhotic patients with ascites has indeed been demonstrated for furosemide and for beta-lactam antimicrobials such as ceftazidime or cefzoxil. In patients undergoing surgery for obstruction of the common bile duct, the biliary excretion of antibiotics such as ampicillin, piperacillin, cephalosporins, clindamycin, ciprofloxacin was markedly impaired in patients with obstructive biliary tract issues. Drugs and drug metabolizing normally excreted to a significant extent via the biliary may therefore accumulate in patients with obstruction and common bile duct. Now we look into the effect of renal impairment on pharmacokinetics and pharmacodynamics processes. Absorption. Renal disease can significantly affect drug absorption, decreasing the bioavailability of oral medication, as kidney disease have associated comorbid conditions that can have a combined effect on various aspects of absorption. Distribution. Fluid distribution occurs in renal impaired patients, leading to a change in the volume of distribution of the pharmacological agents. As the extracellular fluid increases, as in patients with edema or ascites, the volume of distribution increases, therefore increasing the serum concentration. With protein binding and how it affects the kidney. Kidney disease and uremia affects the ability of plasma protein to bind to medications. Uremic molecules in other organic ways displaces the agent. Rise in unbound drug molecule or free fraction of drug thus increases the potential of pharmacological action of the medication, leading to toxicity. Metabolism and elimination. In kidney disease, the metabolism and elimination of medication is reduced. Accumulation of active drug or metabolite may lead to complications, particularly in medications with a narrow therapeutic index. The active metabolites of drug after liver metabolism might accumulate in really impaired patients, leading to metabolite-related adverse reaction. Patients with kidney disease have slower non-renal clearance and prolonged half-life compared to patients with normal renal function. Now, if you look into the concept of loading dose determination, even though if your patient has the renal impairment, steady state plasma or desired plasma concentration is delayed if a loading dose is not given. So, regardless of your renal function, the patient should receive a similar loading dose as patients with normal renal function in order to achieve a rapid therapeutic dose. Then, the concept of therapeutic drug monitoring. For patients with a narrow therapeutic drug index, therapeutic drug monitoring can be beneficial despite dosage adjustments according to estimate renal function. In case of changes in renal function, or addition of another agent without potential nephropathy, therapeutic drug concentration should be repeated. Now we'll look into the pharmacodynamics and how it affects the dosing of renal and hepatic impaired patients. So as you all know, drug pharmacodynamics is what the drug does to the body. This is a concentration time graph, and in case of antibiotics, we have two types of antibiotics. time-dependent antibiotics and concentration-dependent antibiotics. So, time-dependent antibiotics, the duration of exposure above the MIC increases antibacterial activity. That is, this is the MIC, and if the antibiotics concentration um, above the MIC, so how long this concentration is maintained above the MIC determines its antibacterial activity. So, continuous infusion helps to increase this efficacy and decrease the toxicity. An infusion rate and dose must be adjusted to the kidney function. Then concentration, next is a concentration dependent antibiotic. That is, concentration of the drug above the MIC increases antibacterial activity. So for this, once daily dosing can be utilized. Renal toxicity can be reduced if the Cmax is achieved by a single dosing. That is the concept of pharmacodynamics. Now we look into a new concept of augmented renal clearance, which has come of recent importance. Augmented renal clearance, the phenomenon in critically ill patients characterized by increased creatinine clearance and elimination of renally eliminated medications, thus decreasing its clinical efficacy. Patients with severe neurological injuries, sepsis, trauma, and burns have consistently identified at the risk of ARC with mean creatinine clearance ranging from 170 to 300 ml per minute. This results in suboptimal exposure to critical medications including beta-lactams, vancomycin, and increased risk of treatment failure. Therapeutic drug monitoring and identification of ARC may help an important role in aiding clinicians to individualize therapy when their patient's physiology is different than anticipated. So now we look into few case reports and understand these concepts in detail. So the first case is of a 58-year-old female patient with weight of 65 kg. The patient is presented to the ED with complaints of high-grade fever, chills, and flank pain, along with vomiting. Urine routine revealed numerous bacteria and pus cells. Apart from total counts and CRP being elevated, her serum creatinine came out as 1.7 mg per deciliter. Liver functions were SGOT and SGPT at 53 and 23 IU per liter, and serum albumin at 1.9 gram per deciliter. Suspecting a pyelonephritis, the plan is to empirically start on injection meropenem. So how will you adjust the dose of meropenem? The patient's creatinine clearance according to Cockcroft Gold equation is 37 ml per minute, and according to the Sanford guide, patient's dose should be adjusted to 1 gram 8th hourly after giving a loading dose of 2 grams. So this is a normal pharmacodynamics in the patient. If you give a 1 gram 8th hourly dosing, that is the concentration and time, and if you give a 1 gram 8th hourly dosing, you'll have 3 peaks: 1 gram first dose, second dose, and the third dose. But if you adjust the dose to 1 gram twice daily, you'll miss the second peak, and hence the MIC will be the concentration will be below the MIC. So meropenem is a time-dependent antibiotic. That is, for increased efficacy, the meropenem's concentration must be above the MIC for most of the time of administration. So patients with renal impairment, to attain maximum efficacy along with dose adjustment, the infusion rate can also be prolonged to 3 hours instead of 30 minutes. So our adjusted dose will be administering meropenem 1 gram 12th hourly. Instead of giving a 30 minutes infusion, you can give 1 gram 12th hourly 3 hours to increase exposure of MIC, increasing the efficacy of the drug. So therefore, helps the drug to maintain more time above the MIC. Now, moving on, this patient X also grew an ASBL Klebsiella pneumonia sensitive to meropenem and ertapenem, trimethoprim sulfamethoxazole, cefoperazone sulbactam, and a CT abdomen revealed right-sided pyelonephritis. The plan is to complete 7 days of intravenous antibiotics and repeat urine culture to decide on the duration of oral antibiotics. As the patient is clinically improved by day 4, it was decided to discharge the patient on outpatient parenteral antimicrobial therapy with intravenous ertapenem. So, do you think is there any contraindication for ertapenem for this patient? As I had mentioned before, the patient's serum albumin is 1.9 gram per deciliter. There is a high risk of clinical failure if ertapenem is given in patients with hypoalbuminemia. Ertapenem is highly protein bound, that is 90 to 95% is protein bound, which explains its long half-life of 4 hours, allowing convenient once daily dosing. So, the pharmacodynamic target of ertapenem is the active unbound fraction needs to exceed the minimum inhibitory concentration above 40% of the dosing interval for maximum bactericidal effect. Pharmacokinetics and hypoalbuminemia. There is less protein bound drug and greater volume of distribution, resulting in rapid clearance of the free active drug. The faster clearance leads to shorter half-life and overall less drug exposure. In hypoalbuminemia and critical illness, the free fraction of ertapenem increases, leading to decrease in the serum half-life of the drug. An observational study of 279 patients with enterobacterial infection found that hypoalbuminemia less than 2.5 grams per deciliter was associated with 5 times higher odds of 30-day mortality for patients receiving ertapenem compared to those receiving meropenem. Now we look into the second case. We have a 31-year-old female patient who has a weight of 70 kg. The patient is a known case of CKD with a baseline creatinine of 2 mg per deciliter. The patient was diagnosed with varicella zoster encephalitis and was started on IV acyclovir 700 mg Q8 and administered in 100 ml NS over 30 minutes. On day 4 of starting acyclovir, his urine appeared opaque, milky white, renal functions elevated to serum creatinine of 2.8 and urea to 79, and the urine was analysis that revealed crystalluria. What could have been the possible cause of crystalluria for this patient? Crystalluria is associated with drugs of limited water solubility to patients at risk of volume depletion or pre-existing kidney or liver disease. So, acyclovir is known to cause crystalluria. This is an example of acyclovir crystalluria in light microscopy. We can see sharp needle-shaped transparent crystals. Because acyclovir has intravenous acyclovir has limited water solubility and only 60 to 90% is exchanged unstrained in the urine. So if you administer acyclovir in less dilution, it can lead to crystalluria. So creatinine clearance according to the Crocroft-Gold equation is 52.9 ml per minute. According to Sanford guide, if the creatinine clearance is between 50 and 90, you have to give 5 to 12 mg per kg 12th hourly. The dosing can be adjusted as 700 mg Q12H as a patient is CKD. And to prevent crystalluria, we have to administer in 300 to 500 ml NS over 1 hour, also considering patient's total intake as advised. And factors to consider in high-risk patients: maintain hydration, monitor renal functions regularly, and dose adjustment should be made for patients with a non-renal impairment. Next, we'll move on to a case. We have a 71-year-old male patient who is admitted in a critical care unit who is a known case of CLD with a child score of 4 and MELT of 20. Patient has a hepatic renal syndrome and was diagnosed with invasive pulmonary aspergillus. A bowel was taken which grew galactomannan and whose galactomannan was positive of 1.7, and a subsequent culture grew aspergillus. The patient's intake was 2.3 a liter per day and output was 2.1, and SGOT, STPT was 390 and 553 respectively. Total bilirubin was 12.9 micromole per liter and serum creatinine was 1.8 mg per deciliter. The plan is to start voriconazole for this patient. So what should be considered in starting voriconazole for this patient? First, we look into the renal factors. The renal recommendations for voriconazole are: according to MDRD equation, creatinine clearance is 37 ml per minute. For invasive aspergillus, the dosing is 6 mg per kg IV, 12th hourly followed two doses loading followed by 4 mg per kg 12th hourly for up to 12 weeks. The IV formulation of voriconazole is restricted in patients with renal insufficiency as it includes sulfabutyl ether cyclodextrin, which is a solubilizer which can accumulate in renal impairment and cause cellular injury. So, the manufacturer recommends in patients with moderate or severe renal insufficiency, creatinine clearance less than 50 ml per hour, oral voriconazole should be administered. So, dosing for oral voriconazole will be if weight is more than 40, 400 mg 12th hourly for 2 doses, followed by 400 mg 12th hourly maintenance. Now, we'll consider the hepatic recommendations for this patient. Based on the clinical parameters, the child score will be class A and B. For voriconazole, for class A and B, the loading dose standard loading dose should be given and maintenance dose should be half. So it will be 400 mg 12th hourly for 2 doses followed by 100 mg 12th hourly maintenance. And the therapeutic drug monitoring is recommended to prevent underdosing and improve the clinical outcome for this patient. In case of severe hepatic impairment, that is more than 5 times the upper limit of normal, we have to consider using an alternative antifungal. So that was a case to understand the concept of hepatic as well as renal dose modification in patients. Next, we'll look into the third case for today. We have an 80-year-old female on treatment with ceftazidime and avibactam 2.5 gram 8th hourly for MDR Klebsiella, ventilator-associated pneumonia, which the patient developed sudden onset confusion and disorientation. Her RFT and LFT were normal initially, but now she developed an AKI with a serum creatinine of 2.8. And during the course of primarily after a CT contrast with of chest X-ray and dehydration, the patient developed an AKI. So why did the patient develop neurological symptoms? So we have a patient who was on treatment for pneumonia and was given ceftazidime and avibactam. But after a CT contrast test and due to dehydration, the patient developed an AKI. And after that, the patient started developing confusion and disorientation. So as the patient was in ceftazidime, it is understood that ceftazidime can be neurotoxic in patients with renal insufficiency. As cephalosporin concentration increases due to impaired elimination. Increased cephalosporins bind to GABA receptors and displace the binding of GABA, which is an inhibitory neurotransmitter, resulting in hyperexcitability of neurons, leading to symptoms like altered mentation, myoclonus, asphyx, coma, seizures, and status epilepticus. Dose adjustment is therefore required in patients with impaired renal injury for ceftazidime. Dose adjustment based on renal function or discontinuation is crucial in order to prevent ceftazidime accumulation and adverse reactions. So according to the Sanford, dose adjustment will be 0.94 gram 12th hourly. Next, we'll see a few examples of antimicrobials with renal and hepatic dose adjustment. First one is vancomycin. The creatinine clearance is less than 50. We have to modify the IV dose, and oral dose modification is not required as absorption is negligible. Colistin dose modification must be done if the clearance is less than 90. Posaconazole modification must be done for only IV medication if the clearance is less than 50, and oral there is no dose adjustment required. Oseltamivir dose modification must be done if the creatinine is less than 60. Norfloxacin dose modification should be done if the creatinine clearance is less than 30. For sulfamethoxam and trimethoprim, dose modification must be done if the creatinine clearance is less than 30. For tigecycline, there is no renal adjustments, but for a hepatic child score of C, loading dose 100 mg IV, then followed by 25 mg 12th hourly. For daptomycin, modification must be done if the creatinine clearance is less than 30. For fosfomycin, oral dose modification is not required, but for IV, modification is required if the creatinine clearance is less than 40. Teicoplanin, we have to consider dose modification if the creatinine clearance less than 80. And the antitubercular drugs dose modification is required for patients with both impaired hepatic and renal dysfunction. Now we'll look into an important paper regarding the dose modification of antibiotics. It is published by the IDSA. According to the paper, the goal of renal dose adjustments is to achieve equivalent exposure, minimize toxicity without compromising the efficacy. So, therefore, the first 48 hours are critical for patients with bacteremia. Inadequate therapy during these first 48 hours of treatment increases the odds of mortality. So, in patients who are admitted with infectious diseases, renal impairment is acute rather than chronic, and that this impairment resolves within 48 hours in a substantial portion of cases. More than 50% of patients with AKI on admission had resolution of the injury after 48 hours. So, highlighting the potential for rapid recovery of AKI. So, inappropriate dose reduction in the settings of a transient AKI may decrease clinical response in patients with moderate renal impairment. Antibiotics with wide margin of safety. Dose adjustment should be deferred until 48 hours after initiation of the therapy if the renal functions are improving with no risk factors. The potential for toxicity is low but not zero. The risk to benefit ratio must be assessed. Reduce subsequent dose if renal impairment still persists. For drugs with a narrow therapeutic index, deferred renal adjustment carries an unacceptable risk of treatment related toxicity, and therefore the empirical dose adjustment is required for both acute and chronic renal impairment. Now, the take home message is in patients with renal and hepatic impairment, always look for the etiology of derangement, that is, whether it is acute or chronic. In acute cases, initiate the corrective measures, that is, dehydration, hydrate the patient, drug induced, stop the offending drug. Assess the risk factors for patients which can contribute to deranged RFT or LFT, it is age, comorbidities, CKD, or CLD. Make sure you monitor the trajectory of renal and liver functions. In impaired RFT, intake output plays an important role in prognosis. Antibiotics pharmacodynamics and pharmacokinetics should be analyzed. Never always look into the theoretical creatinine clearance and initiate dose modification, but rather assess the patient clinically. Thank you. So these will be the coming sessions for the basic module. The rapid sequence intubation. Next is the base cycle 2 of presentation 13, antimicrobial loading dose and maintenance dose concepts, which will be conducted on May 25th, Saturday from 6 to 7 p.m. Then we have a coming presentation on the basics of evidence-based medicine, part 2 by Mohammed Rashid, which is scheduled for May 27th from 5 to 6 p.m. Next, we have a talk on antibiotic intravenous to oral switch on May 30th from 5 to 6 p.m. Thank you.
A very comprehensive class, Dr. Aisha. I think this session would be beneficial for all the pharmacy students as well as working clinical pharmacists. And here we have a couple of questions in the comment section. First one, how will we approach patients who need antibiotic dose modification with AKI and sepsis? It's a very complicated question.
Thank you for the question. It is very important to consider, like I said, the principles of dose modification in patients. So if a patient has a sepsis, so the AKI can be attributed to the sepsis, that is the bacteremia is causing the kidney injury. So instead of initially first away reducing the dose of antibiotics in the first dose or the second dose, we have to consider what is the reason for the infection. If it is a bacterial infection, so we have to give the antibiotic with the full loading dose and observe the patients for improving renal functions, that is like what is the trend of the creatinine, whether it is improving or decreasing. Then what is the output? Hourly output, not the per day output. If the hourly output is increasing, you can give a loading dose and give full dose of the antibiotic from up to from 24 to 48 hours. So you give the full dose for 1 to 2 days. Observe the patient. If the patient is clinically improving, means the patient requires the antibiotic at the full dose. And if renal functions and the output, the uremia is improving, that means you can continue giving the antibiotic at the full dose. But if the patient is worsening and the renal function are deteriorating, you have to consider dose modification for the antibiotic.
Okay, so it's all depends on the patients and its risk factors.
Yes.
Next, for patients, dose has been reduced due to elevated creatinine. When should we reconsider hiking up the antibiotic dose?
Yeah. So now if we have reduced a patient's dose based on the creatinine, now we cannot continue this until maybe some patients might require a total duration of 10 or 14 or 21 days of antibiotics. So over the process, if the patient has clinically improved and if the AKI was due to an injury to the liver, to the kidney because of an infection, the patient will eventually improve. So maybe by day 5 or 6, the patient's creatinine has come back to normal. We have to consider reducing the antibiotic, increasing the antibiotic, because the patient requires a full dose of antibiotic for completion of the for the infection. We need to clear the bacteremia for the patient. So first thing you have to consider is improving the creatinine values, then improving the renal output, improving uremia, and if the patient is clinically improving, you can furthermore consider hiking up the antibiotic. If the creatinine value is serially decreasing with an increased output and the patient is getting better, so you have to consider, and if this current antibiotic is sensitive according to the cultures, you have to consider giving the full dose of the antibiotic and consider hiking it up.
Okay, thank you, Aisha. So, by this, we are winding up our session. Dear participants, thanks for joining. We admire your interest in learning the basics of infectious disease. So, let's catch up again with another new topic. Thank you.